Hello, thanks for watching this video, which is about a condition called fatty liver, or the medical term that's used for this is non-alcoholic fatty liver disease. My name is Nikhil Inamdar, and I'm a gastroenterologist with an interest in various gastrointestinal conditions as well as liver diseases and pancreatic diseases. Non-alcoholic fatty liver disease is becoming a commoner condition that is being diagnosed on a more frequent basis, and quite often patients find out about it when they have a scan for some other reason of their abdomen or even their chest, and this shows up on the radiological study. The diagnosis is made by demonstrating at least 5% of the liver is involved by fat buildup or fat deposition, either by a imaging study or a biopsy, a histological study. You have to rule out other causes of fat in the liver, such as alcohol, which is the commonest other cause. Certain medications can do it. It can be associated with certain other conditions, including some patients with hepatitis C, and there are also various hereditary causes that can cause fatty liver. When we talk about fatty liver, what we're talking about is the excessive deposition of fat globules in the form of triglycerides in the liver. Now, people ask, how does this happen? Well, everything you eat and drink gets absorbed from the small intestine as small molecules, either fatty acids if you've eaten fats, or various sugars if you've eaten any carbohydrates, and then amino acids if you've eaten proteins. But most of this goes directly from the intestine to the liver. The liver removes many of these smaller molecules and then reprocesses them and then sends them out to other parts of the rest of the body to be used for various metabolic and other processes. However, sometimes the liver will hold on to some of these molecules and reconstitute them, and so long-chain fatty acids get absorbed by the liver, and in some patients, for reasons that are not entirely clear, they have a propensity to hold on to this in the form of triglycerides or fat in the liver instead of releasing it. Now, the body stores very little in the form of carbohydrate. There's only a small amount of carbohydrates stored in the body. So most of the carbohydrates that people eat get converted to fat in the body, or they get metabolized, or gets burnt up for various various processes. Okay, I just want to show you a diagram of what a fatty liver might look like as compared to a normal liver. On the left-hand side is your normal liver, which has a reddish appearance usually, and on the right-hand side is a fatty liver, which even in a real specimen would have a yellowish tinge to it, depending on the amount of fat. The fatty liver can sometimes be enlarged, and this can cause some discomfort for the patient and can also have some effect on the blood flow into the liver. These are pictures of biopsies from the liver that have been taken from various patients. On the left-hand side is your normal liver. This is magnified many times and looked at under a microscope. And you can see these are normal liver cells, the nucleus in the middle. And this is actually a bile duct that happens to drain this part of the liver where the biopsy was taken from, and this is a vein. On the right-hand side is a fatty liver, and as you can see, the architecture, the image looks completely different, looks like a chicken wire situation, where the white spaces represent where there was fat in the original specimen, fat deposits in the form of globules. And these can either be inside liver cells, such as here, or they can be between liver cells. So these fat droplets can actually damage the functioning of the liver cell and can actually cause harm. And that is why this condition cannot just be passed off as being totally benign in some patients. So how is this condition diagnosed? Well, it usually is picked up on scans. And this is brought to attention by maybe a vague discomfort due to the large liver in the right upper area of your abdomen. Sometimes it comes to attention after a patient has some blood tests which show that his liver enzymes, chemicals in the blood that are released from the liver, are slightly or moderately elevated. And this is the most common cause actually for abnormal liver enzymes now. Between 14 to 25% in various studies is accounted for by fatty liver. The condition may well, as I mentioned earlier, coexist with other conditions, including excessive alcohol consumption. And anyone who drinks, in men, more than 3 drinks a day, and ladies 2 drinks a day, and has fatty liver, is attributed to the alcohol rather than this other condition. It is also frequently found incidentally on imaging studies, such as scans, as I mentioned earlier. It could be a CT scan or an ultrasound study done for some other reason. And this brings it to the patient and the physician's attention. Now, there are various subgroups of what we call non-alcoholic fatty liver disease. Majority of them are simply called non-alcoholic fatty liver. This is about 80% of cases. This has a fairly benign course, insidious. There's no damage to the liver caused by the fat in majority of these cases. There's another group called non-alcoholic steatohepatitis. The acronym used for this is NASH, N-A-S-H. And this usually is associated with injury from the fat to the liver cells and the liver structure itself, which results in the buildup of scar tissue over a long period of time. The scar tissue is referred to as fibrosis. But the problem with the buildup of the scar tissue is that excessive scar tissue in the liver can result in cirrhosis. So of the patients who have NASH, 1 to 3% per year progress to cirrhosis. And of these who develop cirrhosis over time, 3 to 5% decompensate. And there is also an increased risk of liver cancer from patients who have NASH. Up to 2 to 3% a year can develop liver cancer. So the NASH is not a completely benign condition. There are patients who develop cirrhosis and then present with complications of cirrhosis later on, who have various features to suggest that they had NASH that resulted in this cirrhosis, but by then the liver is so scarred that you cannot make a diagnosis on a biopsy. But most of these patients, who are referred to as cryptogenic cirrhosis patients, have other comorbidities, other conditions that are frequently associated with non-alcoholic steatohepatitis or NASH. I just want to show you a model of what this progression of liver disease might look like. So on the right here is a normal liver, smooth, red. In the middle is a representation of fatty liver with enlarged liver, and it's basically has a yellowish color to it. And then on the left-hand side here is a cirrhotic liver, this nodular appearing liver, which has developed a lot of scar tissue, the fibrosis, and it's got to the point where you have bridges between different nodules in the liver, and it gives this nodular appearance to it. Now, within this context, any condition that causes cirrhosis increases the risk for liver cancer, which is depicted here in these other yellowish larger nodules. I should add that cirrhosis of the liver can develop from various different conditions. It's not necessarily just from alcohol or fatty liver. It can develop from various viruses, and there are several other conditions. So usually these are all ruled out when we make a diagnosis of fatty liver alone, short of biopsying every patient who has the condition. A little bit on the prevalence of this condition, how common it is in the population. It depends to some extent on the population studied and the age group of the people you're looking at. But it's felt that at least 30% of adults here have this condition in the US. And within certain ethnic groups, especially the Hispanic population, certain Native American Indian population groups, and there are some patients with obesity, there's a much higher incidence. Now, it has been found in children as young as 2 years old. And these folks are at increased risk for complication development over their lifetime. The other finding recently is that males seem to have a higher incidence than females for no obvious cause. The question that comes up frequently is, why does this develop in some people and not in other people? This really, we don't have a good answer for this. It's felt that you need the fat deposited there initially, and then in susceptible individuals, either genetically they're susceptible, or there are other nutritional factors, eat too much of the wrong food, or the bacteria in their intestines send out signals or chemicals that get absorbed that modulate the way the liver works. And this results in development of fatty liver and then inflammation in some patients, resulting in the NASH or the cirrhosis subsequently. Okay, I want to move on to discussing some other conditions, risk factors or associated conditions for non-alcoholic fatty liver disease or NASH. These include patients who are obese, meaning body mass index is over 35. Certainly a large proportion of them will have non-alcoholic fatty liver disease. They found that 90% of patients who undergo a bariatric procedure for weight reduction have this condition. In addition, approximately 70% of adult diabetics will have this condition, and patients with high triglycerides as well, as a majority of those will have this condition. In addition, patients who have polycystic ovarian syndrome or sleep apnea might have this condition. There's also a syndrome called metabolic syndrome, which is defined by any three of either excessive girth, high blood pressure, obesity, BMI greater than 35, high triglyceride levels, high fasting blood glucose, or insulin resistance syndrome are more likely to have this condition as well. So next, how do we distinguish between someone who has the benign condition, non-alcoholic fatty liver disease, versus the more aggressive condition, NASH, or NASH with early cirrhosis? So liver biopsy is much more likely to yield the answer to these questions. However, it has some risks, it's expensive, and is not necessary in every patient who has fatty liver. Any patient who we're not sure about, cannot exclude other diagnoses, should have a liver biopsy, but your physician would have to discuss this with you. There are some non-invasive methods of trying to decide on how much scar tissue has built up in the liver, and there's a blood test which checks for 6 different variables called the NAFLD fibrosis score, which can be used. There are a couple of other scores. One is an APRI score, and another one is an enhanced liver fibrosis panel. All of these are great when someone has advanced scarring or fibrosis. If they have minimal fibrosis, they're not that specific. There's also some imaging studies that can help. There's an MRI study that called MR elastography and MR spectroscopy that can be done. These are very expensive, really only used in some research centers. In addition, there's a newer type of scan called a Transient elastography scan, or a fibroscan, that has recently been approved for use in the US. And this is a little bit like an ultrasound scan. There's a probe that gets applied to the surface between the ribs, and basically some waves, shock waves are kind of sent into the patient, and depending on how fast they move through the patient, the speed is recorded and analyzed to determine how much scar tissue there may be in the liver. It also gives a qualitative assessment of the degree of amount of fat in the liver. I'm going to move on to complications of patients who have developed cirrhosis due to NASH, and monitoring them. The main concern is that their liver might fail. In fact, NASH-related cirrhosis of the liver has become the leading cause of end-stage liver disease requiring liver transplantation in the US now. In addition, most of the liver cancers that occur in this condition in the US presently. Of course, there are many other conditions that can be associated with cirrhosis and liver cancer, but NASH has come up to the top, especially with the treatments for hepatitis C becoming more effective. We're probably going to find in the future that the number of cases of hepatitis C that require transplantation is going to go down, and the NASH percentage is going to go up. Patients have to be screened, monitored for this. We do ultrasounds and some blood tests, alpha-fetoprotein blood tests, to monitor for developmental liver cancer and try to catch it early if it does develop. But I don't want to sound alarmist. This is not, majority of patients don't develop this, but it's something to be monitored for. Right, so let's focus on treatment of this condition. There's no golden bullet, magic bullet for this condition. Initially, efforts should be focused on prevention, prevent people getting this, and particularly this should be focused on children and adolescents who might develop this condition. It is very important to avoid overfeeding your kid because they inevitably, especially with the high carbohydrate diets that are very convenient for everyone nowadays, and pre-packaged foods that are available in high sugar sodas and so on, there is a high propensity, high likelihood they will develop this condition, if not some other conditions related to it. So very important to educate the kids early on and also lead by example at that point. This includes adolescents, obviously a little more difficult there. Avoid alcohol, that's important, even if you don't hit that threshold of 3 measures a day or 2 measures a day for ladies. You should really cut it out if you have this condition. Then effort should be focused on weight reduction. If you have just the benign non-alcoholic fatty liver disease, a 5% reduction in weight actually shows improvement in liver histology, liver biopsies that have been done in studies. If you have the non-alcoholic steatohepatitis, then 10% weight reduction minimum is advocated. And how do you go about this? Well, this is obviously not easy for a lot of people. It's a long-term challenge. Again, there's no magic medicine that helps with this. You need to basically cut down the calories, the carbs, 1,200 calories a day or less dieted on a sustained long-term basis. Not easy. You need to work with a dietitian. Avoid fructose products as well. Remember, the carbs get converted to fat in the liver, so you want to keep the carbs very low. The other part of this is to exercise regularly if you can, 30 minutes of sustained high-level exercise 3 times a week if possible. Again, studies have shown that this can reduce the fat in the liver by up to 80% when they've done serial biopsies, which is not practical on most people. So using the FibroScan, which I mentioned earlier, might be a way of trying to monitor the fat in the liver to see what the effect is of all these measures, in addition to blood tests. There are some medications that have been used for this. None have really stood out much. There is one called obeticholic acid, which has provided fairly good results in phase 2 studies, especially in diabetics with this condition. But it's in a large phase 3, which is the final stage that they look at thousands of patients to see what other side effects might occur and also what the real benefit is on a large scale. So that's going on now, and hopefully we'll know the results in a couple of years on that. Vitamin E has been recommended for patients. Again, this vitamin has what's called antioxidative properties. It seems to reduce inflammation in the liver in patients with NASH. However, at higher doses, there are concerns that it may increase heart disease related problems. So you need to really discuss it with your physician to try to individualize this. The general recommendations on this seem to change every 2 or 3 years. There's also vitamin D has been recommended. Many of these patients apparently have low vitamin D levels. Supplementing the vitamin D after measurement might actually reduce some of the inflammation for causes that are not clear. Caffeine as well seems to protect against progression of the condition. So a couple of cups of coffee might help in this, but make sure it doesn't worsen some of your other medical issues. Then people have tried omega-3 fatty acids as well. This might be a benefit. It probably is not going to harm you. May help with the cardiac issues that go along with this condition. Several other over-the-counter or supplements have been tried, such as milk thistle and resveratrol and betaine. None of these have really stood the test in studies that have been conducted for this. But there are obviously some patients who they seem to benefit. But again, there's no good study that shows sustained benefit on a large group of patients. Metformin and Actos or pioglitazone have been tried, as well as ursodeoxycholic acid. Again, none of these have really panned out, so are not recommended at this time. Finally, you should come to bariatric surgery as a mode of treating this. Now, in the past, there used to be a type of gastric bypass that actually resulted in fatty liver and cirrhosis. They don't do that anymore. So the present laparoscopic gastric bypass that is done frequently, and as well as the sleeve procedures that are done frequently now, do actually show reduction in fatty liver on follow-up biopsies 5 years later. And also reduction in steatosis, inflammation, and scar tissue and fibrosis. So at the moment, this is the best treatment, but cannot be applied to everyone. Now, while this talk is really focused on the liver aspects of this condition, remember it is associated with various other conditions, and one of these is coronary artery disease, which is really the cause of death in patients who do have this condition in most of the patients who pass. And the fatty liver itself is not the direct cause of it. But it is a signal that, hey, if you have this, then maybe these other issues need to be looked at if they haven't been addressed already. So if your physician tells you you have fatty liver, you might want to ask about diabetes being checked out and generalized blood vessel disorders, especially in the heart. There are newer medications being tested. There's a lot of research going on this condition. So hopefully this will all result in better medications and treatment for this, in addition to all the weight loss studies that are going on at this time. Thanks for listening.